Chapter 15, Future Trends in Healthcare. Here are objectives. Now, before we look at the future, we must first look at the past. So we'll take a past and present view before looking at the future view of healthcare. Identify the need of healthcare reform. Compare and contrast healthcare reform proposals. We will discuss the APA of 2010. We'll explain the need for entitlement reform. Who can tell me what that means? Entitlement reform. When it comes to healthcare, what is an entitlement that we are afforded as United States citizens?
Medicare.
Medicare, Medicaid. Items that are entitled to us and protected by our United States Constitution. We'll discuss various state proposals for healthcare reform. Okay. The need for healthcare reform is focused on three main criteria. These have been problem areas: delivering quality healthcare, access to healthcare, and affordable healthcare. We're going to focus on these three items. On quality, and go turn to your book in page 358. All right, before we talk about air as human. Healthy People 2000. Introduced in 1990 as the nation's strategic plan for healthcare. It started by measuring the existing health status of the nation. Established goals for health improvement to be reached by 2000. And here we have Healthcare 2000. Here were its goals. It's going to be interesting to look at these initiatives and these goals, how they change throughout time. But under Healthy People 2000, we were set to increase the healthy lifespan for all Americans, reduce health disparities among all Americans, and achieve access for preventative health care for all Americans. How are we going to promote health? Increased physical activity, nutrition, reducing smoking and tobacco rates, and reducing alcohol and drug abuse. Improving facility planning. It was around this time we started seeing an increased emphasis in improving of mental health. That we started seeing more awareness of mental health being recognized. Reducing violent and abusive behavior, and enhancing our health education. How can we produce, or how can we protect our health? By reducing unintentional injuries, accident awareness, both in the workplace and at home. Improving occupational safety. Again, partnering with OSHA and delivering safe working conditions through our employers. Improving environmental health. You know, a lot more has been realized of the effects of our environment on our health. From secondhand smoke to exposure to certain materials in the workforce, specifically asbestos comes to mind. You know, what are some of the items that we're seeing right now?
Water.
Water.
My husband's on a project right now with the water company, investigating and checking to see where all the lead systems still are, lead in the water lines.
Mm-hmm.
in what neighborhoods to make sure that they know exactly where they're at, because they eventually will replace them all. But there is still like,
A lot of your older subdivisions still have lead
it might not be lead out the street, but it should be lead going into your house.
into your house.
If it's lead going into your house, that is not something the water company's gonna take care of.
No. I lived in an older home here in Jeffersonville, an old historic home that had lead pipes. And it's not cheap to have those pulled out and PVC brought in. All right, ensuring food and drug safety. What comes to mind here?
FDA.
FDA. Where do we get a lot of our food from? International markets being shipped in. So if they are not using the same type of safety protocol that we would here in the United States, we have to have an emphasis on it here, on how we can look. But more than that, looking at what we're putting in ourselves. We continue to see today debates on ingredients labels to warning labels on certain hazardous products. You know, you go in McDonald's now and you see all of the calorie take up on the menu. So again, creating more awareness of food and drug safety.
One thing I noticed when I was in New York was you couldn't get fountain Cokes anywhere. Like to get a soda, a fountain soda, you had to go into a restaurant and get it, because like the gas stations, any place like that, they don't have them, because I guess New York state banned any soft drinks 32 ounces or larger, and so they do not have that. They just keep the like 20-ounce bottles of Coke. They don't have fountain sodas anymore. I guess it's not a big enough market.
And that right now is a lot of states and municipalities even are adopting this tax on sugary drinks, which is, this tax is being heavily combated from your soft drink market. But you've seen even between Coke and Pepsi right now, both of them are looking at alternative drinks. You know, you go all the way back to Pepsi acquiring Gatorade, Coke creating Powerade. Now they're even lumping those two drinks in the sugary substance. I just took my little 3-year-old to the dentist last week, and that was one of the questionnaires. How often does she drink soft drinks? How often does she drink sugary drinks, Kool-Aid, Gatorade? And it was pretty cool that I could put none. But I got thinking, if it showed me how often does she drink her juice, I mean, she has a shot of juice in the morning, but it's 100% juice that I give her. But we've not turned her on to these sugary items right now. She's starting to want to know what mom's drinking and
Want to drink it.
what daddy's drinking, what mommy's drinking, and trying to get on there.
Take drinks. Oh, it's terrible.
Why did you do this?
Yeah, I can't.
Daddy's got an upset stomach. That's why he has to
I
drink.
always tell her it's real hot.
It's real hot.
Yeah.
She knows I like hot peppers,
Spicy hot?
so I always tell her it's real hot.
Yeah.
She says, too hot for me? Yeah, too hot for you. It's got peppers in it. Mommy, daddy's drinking peppers. Preventative services. Starting in 2000, we started looking at ways of not necessarily being reactive and combating an illness or injury, but again, being proactive. Heart disease and stroke, preventing and controlling cancer, diabetes and other chronic diseases, preventing and controlling HIV. And it's interesting, locally here, we've seen, and you go all the way back to the 1980s. And looking around this room, I mean, I'm a product of the 80s. I was born before then, but the 80s were my moment. And part of what the 80s gave us was AIDS. But look at it from then. It seems like we went through the 90s we saw less emphasis. I don't know if it just became more absorbed into society, or we definitely came up with a lot of ways of treating it. Now, it's interesting here locally. What are we under some type of warning right now? Specifically up in Scott County,
Yeah, right, Jeffy.
there's an HIV epidemic.
I told you what I happened now.
About what?
Outside County, what happened?
HIV or
The spread of
Heroin?
Spread of the AIDS. They thought, of course, they thought it was the local prostitutes, but they were all tested and they were negative. But the manufacturing the opiates, had to go out and all that. That's all dissolvable in water. The companies, manufacturers thought, well, okay, they made it to where it would not dissolve in water. It dissolves in blood, though, human blood. Basically, someone would let their blood be drawn, they would dissolve the painkillers, and they would all shoot up in the interview. You have families up there that mom, dad, and kids all have it. There's nothing there. There's no economy. Families, huge families have addiction problems, and they're all HIV infected because they went to that method.
What if there's a will, there's a way, though. There always find a way.
And that's what I found out from one of them. They've been tracking it and researching it up at U of L. One of the research coordinators up there who's been working on it. She says,
I had read where they linked it back to sharing of needles and drug.
it's not the town.
Which brings us prostitution to reducing of sexually transmitted diseases.
Hepatitis is back on the rise too, Norman.
Increasing of immune shots and immunization rates. Preventative services. Again, a proactive approach. You'll hear me use these terms, proactive, reactive, quite a bit tonight, but a proactive approach. Improving data and surveillance systems. Every one of you know more about your dependency on technology and how technology has reshaped your operations, but hopefully how technology has improved the flow of information and how the portability of information, the sharing of it. We talked earlier about Norton's My Chart, even not only sharing within the organization, but sharing outside with patients as well. Health responsibilities, where does it start? With you. The family, your community. Think of the role that each one of these parties has on our individual health care. Healthcare professionals, media. How would the media reach your healthcare?
Like commercials. And like those health minute things that they show on the news and.
Public awareness,
Yeah, advertisements and
education.
stuff, yeah.
Go to the dentist and you see the teeth rotted out and the lungs. I even go to the eye doctor now, and there's warning labels in the office of what smoking does to your eyes. Government. Outside of the Affordable Care and outside of health reform, how can the government reach your health care?
Well, they're implementing, more services for women and children in the Medicaid, government's including dental in the Medicaid now. As far as ACA, they're also doing public announcements on TV too.
Mm-hmm. Think even to taxes. You mentioned New York doing away with soft drinks of 30 ounces or more. New York would also be one of the states who apply a heavy tax on those sugary drinks.
The cigarettes and tobacco use.
Oh,
Tobacco
everybody,
products.
I have never seen so many people smoke in my life.
Really?
Than when I was in in New York, everywhere. And there were smoke shops. They had, like in the gas stations, they had like tobacco, pipe tobacco and everything else. There were just rows of it. And they weren't behind the counter or anything. They just, whatever you wanted, you went in and picked up and you smoked. And if you wanted Swisher Sweets, they were right there and you just picked them up off the counter and off you went. I've never seen so many people smoke in my life. It's ridiculous.
Wow. Now, if you've been to New York, instead of Times Square, you realize you and the 1 million people who were standing there, only a small portion of those were actually New Yorkers.
Right. No. It was the New Yorkers. Trust me, they were hanging
No,
out
but
in the cabs with their
That's
cigarettes.
the joke always, if you're in New York,
Yeah.
New York is so friendly to visitors because no one's really, I'm referring to the city, no one's really from the city.
Right,
They've all ported there,
exactly.
so they all know. Now let's compare what we just looked at. Let's jump forward 2010. All right, starting in 2010, increase the quality and years of a healthy life. Would you say that life expectancies have increased? Eliminate health disparities. It said that this goal would be met by addressing leading health indicators in 5 and 4 primary objectives. Again, promoting health behaviors, health and safe communities, systems for personal and public health, and preventing diseases and disorders. Got a question?
Well, I was thinking, I saw a lot of that stuff in 2000. 10 years prior, did they not make any strides in 10 years? I mean, that was a lot of repeats, that's what we just saw.
A lot of repeat.
It's not got very far.
Phase 1 says we gotta have a vision. So again, a society in which people live long and have healthy lives. What's the mission? Identify nationwide health improvements and priorities. Increase public awareness and understanding of the determinants of health, disease, disability, and the opportunities of progress. Provide measurable objectives and goals that are applicable at the national, state, and local levels. Engaging multiple sectors to take actions to strengthen policies. We're seeing an increased collaboration between these multiple sectors today. Phase 2. Overarching goals. Attaining a high quality and longer lives free of preventable disease. If you feel urged to say anything during any of these, just kind of, no, feel free to speak up.
Try not.
We're going to go through, and as I said, once I kind of set this, what I'm doing is setting the tone. We're going to go back in time here in a minute to look at what you're noticing is where we started. All right, achieve health equity. Eliminating disparities and improving health of all groups. Again, this emphasis on health of all groups. Creating social and physical environments that promote good health for all. Okay, again, I just think of smoking, and I think of how the smoking ban, as we'll call it, how it started in government offices, and then how it has gained in popularity. I mean, it's rare that you go into a restaurant right now and you see someone smoking, unless you're in Clarksville.
Richmond free too. As far as I know. I don't know that any place has smoking anymore.
Clarksville, you can still smoke in Clarksville. If you as an owner have the right to restrict.
Oh, okay. I see
But
most restaurants do.
I'm pretty sure that you can still smoke in Clarksville.
Yeah. Let's say Burger King got ashtrays.
It does not.
Burger King has ashtrays.
They put you to have it your way.
Promoting qualities of life across all stages. All right. Let's start with health reform. To err is human. All right, flip to page 358 in the book, and this is where we're going to start. All right, in 1999, the Institute of Medicine, or the IOM, published To Err is Human, which reframed the quality movement from improvement to the reduction in errors. So the focus was now on reduction of errors. It estimated from that research that medical errors kill between 46,000 and 98,000 patients every year. An additional 1.2 million suffer an adverse event caused by the hospital that resulted in an extended hospital stay or some type of disability. Of that amount, more than 1/2 of the reported incidents were avoidable. So going back to my opening statement, the need for national healthcare reform has focused on 3 primary areas. First, access. 16% of Americans without insurance. If you look at the chart on page 359, in Exhibit 15.1, the overall age group, starting with under 19 all the way through 65 and older, the overall age group, 84.6, have insurance. Okay, so we're going to say approximately 15 to 16% of those are without insurance. Available programs. We not only need to allow Americans to have access to health care, but we need to put available programs in there. Once they access it, we need to have programs for them to access. Okay, one program, Medicare, Medicaid. These are our entitlements that we were talking about before class. Aids to families with dependent children. Your state CHIPS program. Here is that table. What age group represents the largest uninsured? The what?
Under 19, the children.
The under 19. And then if you notice 72.8, 19 to 25, 26 to 34. Once we start to see some increase in insureds, starting at the 35 to 44 category. Now, what group here, when we look at the 2 extremes, what 2 groups probably depend on healthcare and utilize healthcare more than any other?
The young and the old.
The young and the elderly. Okay, so we see 65 and older, we have a real high percentage, 98.5% are insured in that group. But look at the 19 to 25, 73% not insured. Looking at your own lives, when did you take the most risk?
When you were young.
When you were young. I hope. Okay, so when we look at not only access to care, not just being on the disease front, but think about it again from the accident front and those items, those notices of being preventable diseases or preventable illnesses, risk reduction, creating a safer environment. All of these are going to be on the younger group. All right, one concern from 2012 is, yes, we've seen an increase in insureds, but we see it not at one of the concern is we're not seeing it at the lower age groups when care might be most needed. Health expenditures in 2009. All right, now as we age, we see that total personal health care expenditures rises as we age. So this is per person at age 65 and older in 2009. I think it's safe to say that these rates and these numbers would be a lot higher today. And in 2009, $10,000 per person. Real quickly, husband and wife, $20,000 a year at age 65. What's your life expectancy?
78, isn't it?
77, 78. Okay, so there's going to give you 12 years. Multiply it without even adjusting it for inflation. You're going to see the amount, and you're going to see the burden on Americans in the higher age bracket. Again, these are Americans that are in retirement. This is something that, again, as a retirement planner, one of my biggest concerns is saving money. You've heard me say that before, saving money for healthcare. It's because of numbers like this. There was a study done a couple of years ago through a partnership of United Healthcare and Fidelity, and I forget the accurate number, but I know that it was a retiree had 2 years ago retiring could expect to spend north of $200,000 in retirement on healthcare alone. That would not include any extended stay or any assisted living or medical community nursing homes. If you find yourself in one of those, it goes quick. You know, private care right now, what, $7,000, $8,000 a month would not be unheard of in this market. Our office writes checks and sends them out to homes throughout Louisville, and I know we write them in those amounts. All right, healthcare reform. We said we had to focus on 3 problems. We talked about quality, access, and cost. Your federal government is now the single largest payer of healthcare expenditures in 2014. Where does your government get that money to pay for those health expenditures?
Taxes.
I mean,
Taxes. All right, so the argument here is to reduce cost, and this argument alone is far more compelling for both employers if we pull out the government and we focus on the other 2 parties that are paying the bills, employers and employees. Okay, so what this is putting them on, again, what effect is that having on our economy? All right, I think our government, I think employees, you're paying it right now, your employers are paying it, all 3 are going to come in here and say, costs are too high. All right, now, look at page 360. When we put this burden on, here I'm putting my economic hat on, but again, putting this burden on employers and putting this burden over in the private sector, what's it causing a lot of employers to do?
Stop offering. We're cutting people's hours back to their part-time so they don't have to pay their health insurance.
Okay, they're cutting hours back, but before we even look at a reduction in pay, if you put the responsibility and the burden, and I don't want to use the word burden, but if you put the responsibility on the employer to pay, who ultimately pays?
Employees.
The employees. If I'm an employer and I'm only budgeted X dollars for your entire position, I can split that through direct wage compensation, or I can put that in an employee benefits program. Okay, and if more of that is going over toward the employee benefits, again, I'm taking it out of what I might have paid in wages. Okay, if I'm reducing your wages, yes, you are getting health care, but your take-home pay is actually staying stagnant or decreasing. Okay, so when you see right now economic talk of growth of real wages and how it is stalled, this is one example of what's causing it to stall. The amount of money you actually take home in today's dollars and the purchasing power that that money has is not growing at as fast of a pace as some other numbers you hear. When you hear government officials out here talking, okay, your real wages of what you're actually taking home and the purchasing power that it has is not growing as fast as you might think. State and local government pays 6%, and professional providers. So here, professional providers and hospitals are the larger recipients of healthcare dollars. That should be considered. Okay. Do I need to recap real quick GDP? It's in economic terms, gross domestic product. Per capita. Okay, so this is going to say what Americans are spending of all of our economic output, what amount of dollars is spent toward healthcare costs. In 1950 to 2000, and let's just look at 2013. Okay, your asterisk there for 14, 15, and 22 are going to be estimated. So let's just stop even if we go to 13 and look how that has grown. Simply look and narrow this down. Look at it from 2000 to 2010. It doubled. And when we look at it from 2010 projected forward to 22, you know, we don't quite double during that time period, but we still see it rising at an alarming rate. When you look at this number right here, and you look at these health expenditures, who is the largest payer of healthcare costs?
Medicare.
Government. When you hear talks of budget problems and deficits, this is a big driver of that data. This is an economic problem. This is a budget problem. This is our deficit problem. All right, so True Health and Analytics. Now, Robert, earlier, before class, how much were you saying in the local Louisville community?
I'm trying to remember what that article was. I think, quote me on it, I think it was like 350 million for the state of Kentucky.
350 million for the state of Kentucky. Look at it from a national level. $700 billion unnecessary health spending. Of this amount, 250 to 325 billion was wasted. 125 to 175, fraud and abuse. When we see a cost skyrocketing, and I just said that's an economic problem here in this country, and you look at these numbers here, I would say we got a lot of room for cleanup. So again, the title of this tonight's class is The Future. How are we going to clean it up? How are we going to increase efficiencies? Be thinking of that. 100 to 150 billion on admin system inefficiencies. Provider inefficiencies coming in 75 to 100 billion. 25 to 50 billion on lack of care coordination, and another 25 to 50 billion on preventable conditions and avoidable care. Does anything there jump out at you?
I thought the lack of care coordination would be more.
What do you say? It says avoidable care. We're back to the scenario of going to the ER for a stubbed toe, and it makes me think, well, who's, how do we stop? We can't stop that. Can't stop people from coming to the ER to be seen. So is that avoidable care? I mean, what is avoidable care?
I mean, if you make them have to have some ownership and pay some of the fees they incur while they're there.
I think avoidable care, it's just my opinion, just based off this alone. I think avoidable care goes with preventable conditions like communicable diseases like hospital-acquired pneumonia. Then the care that goes into getting somebody over that.
Or if somebody doesn't take their immunizations.
Yeah, something like that. Something that is something that should have been prevented, and then the money goes into that afterwards. Once again, I'm surprised that it's that low. I'm surprised that one's that low too.
I agree. I think it would be in the same examples. I think I shared just maybe 3 weeks ago, my dad was in the hospital and required a stent. That procedure was seamless. But 3 hours later, he noticed that he was bleeding through the artery in his thigh. He only noticed that when he went to the restroom. He noticed he was in a bed of blood. Now, he is still bruised from just below his groin to just north of his kneecap. He looks like somebody took a baseball bat and hit him. But because of that, his stay in the hospital was extended for 2 days because it was such a nasty wound, and because of it involving the heart and the circulatory system, they wanted to make sure he was completely healed up and making sure he was completely, they wasn't going to send him home and him bleeding, and they wanted to make sure that the bruising and everything that they saw, it was not going to advance on him when he went home. I consider that to be an avoidable care. Okay, so let's start with, I've set the stage for where we are today, I dangled the carrot, where we're going in the future. But now let's back up at this moment and take a look at where we come from. Early reform. Okay, so the discussion regarding healthcare reform and universal health coverage has a long history in America, beginning with Teddy Roosevelt in 1910. Now, That might be hard for many of you to believe, but in 1910, Teddy Roosevelt floated the idea of universal health care. That was defeated, and prior to 1994, we didn't see a whole lot going on in the health reform arena. So prior to 1994, what we saw was, well, we didn't see a whole lot. What we did see, we'll call it reactionary. And that was Congress got together whenever there was an economic threat or whenever there was a threat to health care, Congress got together and tried to enact some legislation to patch what had just happened. If an alarm bell went off, we reacted and we tried to pass something, we tried to put a patch. There was no future vision, there was no guiding principle for us to build into the future. All right, 1973, before 1973, let me interject this. What did in healthcare reform, what did we get in 1965?
Medicare Medicaid.
Medicare Medicaid. These are entitlement programs. So I would, if I were writing this slide, I would have put 1965 Medicare Medicaid. Jump forward to 1973. Congress enacted and passed legislation to facilitate the growth of the HMO market. Who can tell me what an HMO is?
Health maintenance organization.
Health maintenance organization. What's its characteristics?
If their gatekeeper is restrictive access to healthcare.
You have to have a gatekeeper, your primary care physician. Okay, I've got a courtesy of Humana. We'll see the HMO over on the left. And then something we got after the PPO, but let's just focus on the HMO. All right, so that gatekeeper, we'll call that your primary care physician. And this is going to be the person that's going to coordinate all of your services. Is a referral needed? If you, as in this example, if you needed to go see an allergist, who must you go consult with first? Your primary care physician, and that person is going to refer you out and give you that referral. We start to see the terminology of in-network. So HMOs do not offer coverage for care from an out-of-network provider. Because of these restrictions, HMOs are usually cheaper in today's market. Usually find them at a lower premium cost than PPOs. But HMOs put the emphasis on the primary care physician and the relationship between the patient and the primary care. What did we get in 1983?
CRG.
All right, starting in 1983, we ended Medicare cost reimbursement for hospitals and initiated a competitive environment. And that was done in 1984 when Congress passed the Deficit Reduction Act, or DEFRA. As we look at some of these acts, follow along with me in the text. I'm on page 362. Now, the Deficit Reduction Act limited the amount an employer could deduct from health benefits for employees. Now, again, go right back to saying if we reduce the amount that employers can deduct for health benefits, do you think employers would come and find a way to pass that cost on to its employees still? There still would have to be created some type of sharing. And again, that could be through other compensation reductions, paying you less in the form of wages to cover more of the expense of healthcare. I can tell you in today's, we're getting ready to have, in a couple months, we're going to start open enrollment again. And I can't talk about that principle enough. As I work with small business owners here, and I'm going to define small business owners as 200 and less employees when I talk about healthcare. And this is the number one thing that is on their mind year after year after year, not just in open enrollment. As soon as open enrollment ends in January, we're going to start looking at ways again on what can we do and what measures can we put in place to try to control costs. I said in practice, with a lot of employers who struggle with paying for health coverage. And what we've seen is those that can pay are very fortunate. Truth is, most cannot afford to pay. We put more of that emphasis, even in the paying premiums, putting more of that emphasis over on the employee. Or we've seen a carve out or a hollow out of plan coverages. All right, 1992. What happened?
That's where the DRG came into play, right? I thought it was in the 80s then. This Medicare charge-based reimbursement for physicians and initiated a competition or competitive environment under prospective payment in 1992.
All right, because in 1989, Congress passed the Omnibus Reconciliation Act. And that ended Medicare charge-based reimbursement for physicians. Now let's look at this from a legislation reform. So we're coming through the 60s. I've got us up into the early 90s. We're getting ready to rock and roll. Okay, so what we saw, the 90s, you notice a lot of change here. You notice a lot of acts that were introduced from 1973 through 89. If there's that many acts passed, are you going to think that any of them were successful? No, no. Again, they were all reaction-based. So we move forward to the early 1990s, and throughout the rest of the 80s, the early 90s, we saw a lot of bills continuing to pass through our legislation branches. We saw items of an incremental proposal. We saw single payer proposals. And we saw employer-based proposals. Someone tell me, what is a single payer proposal? Tell me who bears the responsibility, an advantage and a disadvantage.
Single payer is when the government is the only payer, only healthcare provider, payer for everyone.
The government pays it all. What's the advantage?
Supposed to be able to contain costs.
Universal coverage.
Universal coverage, containing costs. Again, you're using the largest entity to pay for it. What's the disadvantage?
You lose all competitiveness, competition.
Well, you lose all competitiveness, but then at that point, you're shifting responsibility from the private sector into the public sector. Again, where does the government get that money from?
Well, taxes.
Okay, and the argument's going to be who's better suited to run this, the private sector or the public sector. So we see Health Security Act of 1993 and the Meta-Planned Healthcare Act of 1993. Both of these were floated through the House and did not stay with us. All right, what about an employer-based?
Just means the employers provided insurance.
Okay, so under employer plan, the employer should provide health insurance for their employees. What's the advantage?
Decrease government spending.
Decrease government spending. What's the disadvantage?
Less flexibility with maintaining your business. You hire less people, you'll find ways around being able to, have to offer health insurance. It's kind of.
Well, you're actually going to put the burden on the business. And if you're a business, I always go back, what's your primary objective in the accounting world? To maximize profit. Now, if you're solely responsible for providing health coverage, what's one way that you could
Not hire people that, already have like diabetes, cardiac disease, smokers, anything like that that's gonna cost you more in the health field. You're not gonna hire them, or you're gonna get rid of them, or you're just not gonna want them there.
You're not going to want them there.
Unfortunately, you can't put that on an application though.
Correct. You would get rid of
High risk.
high-risk workers. Okay, so we see here, Health America of 1993. That was an act, that example. All right, what's a managed competition proposal?
Almost a free market, but it's still run by the government.
A health reform idea that blended government regulation with free market competition. All right, how would this work? That almost sounds like an oxymoron. Government regulation, free market competition. Both involve two different economic thoughts.
Basically, the healthy people pay for the sick people.
Healthy people are going to subsidize the sick. All right, what's a disadvantage?
Healthy people are gonna subsidize the six.
Healthy people are going to subsidize the sick, or the sick.
It'll make everybody participate. And
Everybody would have to participate. Kind of sound familiar?
Mm-hmm.
Okay, this was first proposed in 1993 as the Managed Competition Act. Now, even during that time frame, all of those proposals that were floated through, none of them were successful. None passed. So they were all proposal, none passed. If we review them all, though, if you take a look at each one of the advantages, and let's compare the disadvantages, but take a look and treat these broadly rather than independently, treat them broadly, you're going to follow how Bill Clinton got, I'll quote, President Clinton got his healthcare plan passed. Excuse me, how he had it right to the brink of being passed, but what caused the demise of it? Okay, if we look at all three of these collectively, I'm going to show you again how he was close to getting universal health care reform passed, and then where was the demise at the end. Clinton's plan. What was President Clinton in favor of doing?
To achieve universal coverage.
He was favoring employer-based proposals.
He wanted the best of both worlds, basically.
He wanted to promise lower healthcare costs. So his idea was he went in and favored employer coverages, but he tried to convince employers that he could lower costs in order to gain their support. Why? Where did it derail?
Congress.
Conservatives at the time.
Conservatives never voted on it.
Yeah.
Congress didn't vote on it. All right, they cite several mistakes in his strategy. The insurance industry resisted the insurance reform that was even necessary. At that time, the insurance companies said status quo was good. Conservatives characterized the alliances of cooperatives and that the goal of universal coverage would lead to endless rules and legislative demands. Okay, in the face for calls for a balanced budget, conservatives characterized the act as an open-ended entitlement. And I want to use and I want to highlight that word, an open-ended entitlement. All right, now after the failure of the Clinton proposal, no one was willing to introduce anything else right away. The idea was that we would let the free market control all healthcare costs and we would rely on competition. Now, the first major piece of health-related legislation enacted after the Clinton plan was defeated was the Health Insurance Portability and Accountability Act of 1996, otherwise known as HIPAA. You experts tell me about HIPAA.
Well, I can't because it's confidential.
You can't because it's confidential. Good. Good point. Your message is noted.
That's only on a need-to-know basis.
On a need-to-know basis.
Need-to-know basis. That's your rule. Need to know. Do you need to know for your job? Then yes, you can look at it. It allows people to take their health insurance to, with them when they left employment. Is this where the COBRA thing came in? When I let you continue your, no.
No,
I'm
this
not
is where
100%
you
sure.
can't,
Nobody can release your medical records without you.
Well, let's look on page 365. First, it was insurance reform to protect currently insured people from losing coverage as a result of job change or family illness. And required insurance companies who will offer small group coverage to make policies available to all small groups. So if you were insuring someone and they lost their job, they have the right to take insurance with them. Now, is that way? That sounds like COBRA. All right, it introduced medical savings accounts. What else?
Mandated standardized electronic billing, claims, remittance, so that everybody's claims formatted the same way, which made it easier for electronic computers to read the billing and get out the payments faster.
All right, so administrative simplification, tax rule changes. How did it combat Medicare Medicaid fraud and abuse charges?
Deductible, isn't it?
Excuse me?
Just established.
They
Because I don't think that they were established before then. I may be wrong on that.
I think they needed a definite, definite fines and a certain amount.
So we can say they started to combating a reduction in them
actually-
by bringing them to this is say increasing awareness of it and penalizing anyone who was found to be abusing these.
And actually appointing people to actually look into it.
Actually
To
creating a
track.
task force to review and investigate. So again, we start to see here important legislation that we're still operating within today. Now, the very next year, 1997, brings us the Balanced Budget Act. And what does the Balanced Budget Act give us?
Increased access.
Allowed managed care into Medicare, Medicaid. Business.
What else did we get?
Kids care.
Kids care,
Expanded coverage for children.
expanded coverage for children. Medicaid managed care. What's this SGR?
Sustainable growth rate, which is the increase physicians would get each year from Medicare.
All right, so under the kids' proposal, kid care, this act was going to provide $23.4 billion over 5 years to expand health coverage for children whose parents' income is too high to qualify for Medicaid, but low to affordable private insurance. Be interesting to see $23.4 billion over 5 years. Also established a sustainable growth rate, which calculates the amount of increase physicians would receive each year for Medicaid or Medicare. How is that being followed today? What's that tied to?
Affordable Care Act.
Is that benchmarked to inflation?
Yeah, sustainable growth and cost of living and inflation.
Okay. Let's jump to 2003. MMA of 2003. This is going to increase payments to providers, allow for prescription drug coverage to Medicare beneficiaries. In 2005, here we have DEFRA of 2005. Medicare, Medicaid, and the SHIP Extension Act of 2007. Who wants to tell me about that?
Gave us a 0.5% Medicare payment increase for the physicians for 6 months. Gave an extension of transitional medical assistance eligibility for Medicaid beneficiaries for 6 months. Extended funding for the program through March 31st, 2009 for SHIP.
All right, 0.5% medical payment increase for physicians, extended transitional medical assistance to Medicaid beneficiaries for 6 months. Now, Medical Improvements for Providers Act. What was this going to do? Cut $12 billion. Y'all follow with me in the book. All we're doing is reading right out of this. All right, this is going to cut $12 billion from Medicare Advantage plans over 5 years and $48 billion over 10 years. It was going to prevent any pending statutory 10.6% in Medicare physician reimbursement and provide a 1.6% increase during 2009 and an additional 2%. So this was going to cut spending in Medicare Advantage plans and specifically prevent any pending statutory physician reimbursement. Now the last one we're getting up to in 2009. We're getting ready to rock and roll. 2009, what did President Obama bring us?
ACA.
All right, first piece of that was
American Recovery and Reinvestment Act.
American Recovery and Reinvestment Act of 2009. This was going to provide $224 billion for education and healthcare, as well as entitlement programs. States were going to receive Medicare, Medicaid relief in the form of what they had to provide. So look at these look how we opened this and some of the emphasis, and we're going to see a lot of this, you know, from healthy, we'll just say healthy 2010 and healthy 2020, these visions and how these have played out in this legislation. Okay, we were going to say that it would save existing jobs because, again, it was going to lower costs and allow employers to create new jobs. It was going to stimulate economic activity and invest in long-term growth. Adopt unprecedented levels of accountability and transparency in government spending. What else were we going to get? $288 billion in tax cuts for millions of working families. $275 billion in federal contracts. $224 billion for education and healthcare, as well as entitlement programs. And then compare this from the top to the bottom. The plan was designed, yes, here's what it was gonna spend. That's a lot of money. It was designed to make up for that through these top 3 bullet points. This is what was intended to make it work. Now, in 2010, we have signed into legislation what?
Patient Protection and Affordability Act, Affordable Care Act.
Senate version.
The Senate version of the Affordable Care Act. The House had the Healthcare and Education Reconciliation Act signed on March 30th of 2010. At that time, both laws were going to cost $940 billion over 10 years. It was designed to provide coverage to an additional 32 million Americans. All right, so if you look up at the board, here's a timeline of where we go. Remember, it was first started, these are your main points to show where it's flowing. First floated through President Teddy Roosevelt. You see a large gap from 1910 to 1965. 1965 gave us our 2 major entitlements, Medicare and Medicaid. 1973 brings us HMOs. We see a lot of legislation floated during this time. None of these were passed. The Clinton plan failed. In 1997, we got the Balanced Budget Act. In 2003, Medicare Monetization Act. And all of this led us up to where we are today. The Affordable Care Act of 2010. Again, these provisions were to expand coverage to 32 million people. Reduce rates of increase in Medicare and Medicaid spending. Adopt several delivery system reforms. Provide grants and loans to improve workforce education and training on healthcare issues. There was a provision to reduce waste, fraud, and abuse in Medicare and Medicaid. It imposed new reporting requirements for tax-exempt hospitals. Was going to put significant restrictions on physician-owned hospitals and prohibit new facilities. How was this received?
Depends on who you are.
Say,
Well, let's just speak for the country. What was the initial reaction to this?
That was great.
It was unconstitutional.
It was unconstitutional.
Some people felt like it was needed.
It was
Some type of reform.
okay, yeah, yes. I think the majority of people felt like it was needed, just based on election outcomes. But 26 states challenged it as unconstitutional. And then in 2012, our Supreme Court rules what? The individual mandate unconstitutional under the Commerce Clause. Individual mandate constitutional as tax. That right there is what pushed it into place. Okay, it was unconstitutional in the form of commerce, meaning you could not force a state to come in and produce its own exchange. But if you were going to pay for it in the form of a tax, and you couldn't just make people pay for it, you couldn't just charge us, but if you would just come out and say what it was, we're going to tax and we're gonna pay for it through taxes. Congress can enact taxes. Congress did enact taxes. This was their legal opinion.
That last sentence says it all.
It is not our job to protect the people from the consequences of their political choices. Well, if you compare that to the very first sentence in the second paragraph, members of this court are vested with the authority to interpret the law. Now, what happened in 2014? Because it goes back to them.
The Religious Freedom Act, where certain companies were being told they had to give contraceptives to their employees, and it was violating the 1993 Religious Freedom Restoration Act. Hobby Lobby did not want to provide contraceptives to their employees. It was against their religion.
So we have the Religious Freedom Restoration Act. Protecting the free exercise rights of corporations protects the religious liberty of the humans who own and control those for-profit companies. Now here we are going to go out to Medicare Medicaid Extension Acts of 2010. We have the Affordable Care Act picked up, and now later we're going to have Medicare Medicaid extenders. This was signed by President Obama on December 15th for 1 year. A 25% reduction in Medicare physician payments to take effect January 1 of 2011. The 25% reduction in Medicare physician payments was the result of the Sustainable Growth Act initiated in the Balanced Budget Act of 1997. That was the act that was cited. Now, 2011. You know, by the way, what's the penalty if we don't have health insurance right now? What's our penalty?
I'm not sure what this year's.
It's 1,500 years. You mean if somebody, like a young person decides not to take insurance?
Yes, well, anyone, not just a young person, if
It
anyone.
was like 90 or some $300 a year.
It's more than that.
Is it more than that?
It's like 1,000 or 1,500.
Yeah.
Is it?
Maybe more than that.
It's the higher of 2.5% of your taxable your adjusted income. So 2.5% of your income or $695,
Wow.
Whichever's greater, whichever's less.
whichever is greater. I went back and looked. In 2014, it was $95 a person.
That's the one I remember.
In 2015, it was $325 a person. We see it increasing. In 2016, 2.5% of income or $695. Okay, as a tax preparer and reviewer, you know, I'm quick to point out $95 was not a whole lot. And a lot of people I know who I saw come through my office simply said, I'll just pay the $95 penalty. Now, $325. We see a pretty good jump there. I saw less people coming in and making those statements. We jump to this year, and if I say 2.5% of your income, just take a look at your income. This year, we're gonna find some substantial penalties for those electing not to be insured. And by the way, if you're uninsured for 1 month, you could be subject to that penalty. If you go an entire month with no health insurance, you could be subject to that penalty. All right, so in 2011, we want to talk about, you what? You want to take a break? Okay.
I didn't even sleep in the
I was trying not to.
bus.
I'm like, I gotta get up more. I got up too early.
All three, so.
I was trying so hard. I was like, I gotta get up and walk.
Let's wrap up this discussion on the Affordable Care Act. Okay, so we saw shortly after 2010 that guess what? This plan might not be working initially as we projected. We've got to start looking at ways to battle costs. So on August of 2011, President Obama had to go to Congress and request that we raise the debt ceiling. Now, guess what? We're a country in debt. That did not go over. Plus, you had a Republican side of the House here too, but they did not take kindly in wanting to raise the debt ceiling. In response to that, we did get it. We did raise it. By the way, look at what our debt has increased. I'm gonna go all the way back and say in the last 8 years.
$9 trillion.
What our debt has increased. We had to raise the debt ceiling. That wasn't the first time. We had to raise our debt ceiling. But in response to that, the Republican Party, we won't talk politics, but it was the Republican Party that came back and wanted and used that as leverage. They threatened to shut the government down. And as a result of raising the debt, we have the debt ceiling, we have the Budget Control Act of 2011. This is going to reduce discretionary spending by $1.2 trillion over 10 years. Discretionary spending is capped each year for 10 years. And I focus on discretionary spending. If spending caps are exceeded, there are across-the-board cuts called a sequestrian for all discretionary spending with the exception of military pay. So if that spending cap is breached, across the board, all discretionary spending has to be cut. So before, you could target particular areas of discretionary cuts. If you breach it, across the board. Maintain spending on fraud and abuse investigations, and was going to create a 12-member committee to develop recommendations to reduce the deficit by $1.8 trillion over 10 years. All right, now, of those cuts that we saw in, okay, those automatic spending cuts was going to be worth about $100 billion, or about 8% of the annual budget then. Now, again, we look at payroll taxes. This is discretionary. Just note that with these entitlements, we'll call Social Security, who funds Social Security?
Taxpayers.
Taxpayers pay 6.2% of your income. So I'm going to say employees, wage earners, pay 6.2% in the form of payroll taxes. Who else pays that?
Employer.
Employer also pays 6.2%. up to the first $110,000 of earnings. Medicare. What's the payroll tax on Medicare?
They're on the same, isn't it?
1.45%, and you pay that. There is no earnings cap. All right, here's our federal budgeted spending as a share of GDP. All right, so Social Security spending, look at Medicare, Medicaid. We look at the amount of interest on our debt, other spending. So here are entitlements, and look at Social Security. And we see the interest on the debt. Now, at that time, the Republican Party was going to get 18.7% through 2022. Okay, this is going to be their number. President was going to get up to 19.8% for average annual increases of 19.4. This is what this budget is going to be growing by. Okay, and we said that back here, President was going to get 1.8 trillion over 10 years. Okay, of that 1.8 trillion, we were going to get this from tax rates on the top 2 income categories. All right, over $950 billion were going to come from those 2 high tax income categories. The remainder was going to come from an overhaul of the tax code in 2014. And again, taxpayers under the $250,000 mark were supposed to see tax decreases. All right, so top 2, this cut was going to come from taxing the top 2 income earner wage brackets while trying to give discounts to the lower tax. Now what happened? The fiscal cliff. Now this is a time of what we described the end of 2012 during the Budget Control Act of 2011. All right. This act was passed during the Bush administration, and during that time we were receiving payroll tax cuts. So that's 6.45 could have been 4.9%. Tax breaks to businesses. Alternative minimum taxes. Okay, this is to say that if this is an act passed in the tax code that if you receive a lot of your money in the form of passive income means you don't have a job where you're earning a wage, that's an active income, but if you are surviving off of dividends, interest, something where you just sit back and collect it. So alternative minimum tax is a measure to ensure that those people pay some form of tax as well, some form of income tax. Those were going to start to increase. And then, so you had all these tax breaks that were going to expire at this time. Then all of a sudden, you're going to introduce the Affordable Care Act, which look back to what we just saw, the spending on health care and who's paying for that. You had all the tax cuts expiring, all of a sudden you're introducing increases from the Affordable Care Act. And then at the same time, our government is going to have to be forced to institute automatic spending cuts as a way of paying for that. We define this as the fiscal cliff. Okay, now of these automatic spending cuts, again, we were going to get about $100 billion off of this. The Relief Act of 2012. So anyone earning over $250,000 is reinstated, phase out of tax deductions and credits. All right, under President Bush, capital gains taxes were decreased down to 15 and some down to 10%. That would mean if you held an investment and you sold it, and the gain that you had off of that investment, this is the capital gains tax. So this is the tax that you would pay on that gain. That was allowed to increase back up or expire, so it increased up to 20%. Dividend tax rate also increased. Under the President Bush plan, your dividends, if you own the investment for longer than 1 year, it's called a qualified dividend, and you pay no more than 10%. So under this Relief Act of 2012, taxable incomes over $250,000, they pay a higher dividend rate. Estate taxes increased from 35% to 40%. Okay, so this would be the amount of money, $5.25 million, that you would pass from one generation. So of that amount, 40% is due to taxes. Okay, now remember, alternative minimum tax is going to be indexed to inflation. Payroll tax holiday was going to expire. That's where you went back up to 6.45%. And law to generate $600 billion. So this was going to generate $600 billion in tax revenue over 10 years. Now, I could go from right here and shift this whole conversation to an economic discussion on capitalism, or I could have just an economic discussion on this. Usually when I see this, I think I always call it the Robin Hood effect. And I don't think if you're probably under this limit, no one, or you might not complain. But the argument is always going to be, does this restrict economic growth? I want to tell you, the proponents are going to say, you've done well. We'll take taxes from you and give them down to the lower tax, and we'll afford these programs. You'll pay for them. The opponents of it are going to say it reduces and restricts economic growth. All right, so here we talk about this sequestrian. All right, this got delayed for 2 months. We had also extended, so we were not going to have this sequestrian right away. The president got to defer that. Extended for 1 year federal unemployment benefits. And that came in a cost of $30 billion. All right, so physicians did get a 1 year suspension from that reduction that they were going to face. Members of Congress had a freeze pay and extended portions of the Farm Bill. So here's going to show if we look at income levels, so as a percent, the tax burden as a percent of income. Okay, so 33.9%, someone was earning $153,683. They're going to pay 34%. Okay, roughly 8% of that's in the form of state, and 5% in the form of local, and approximately 15.8% to the federal government. Okay, the lowest tax burden. So we've seen a shift definitely from the higher earners down to lower wage earners. Just going to illustrate it in the form of percentages. All right, the bipartisan act. We're going to have two quick conversations. 2013, again, our government was ready to shut down. This eliminated many automatic spending cuts and delayed for 3 months physician reimbursement. What I want to talk about, the rest here, go back and read about the governor and where we go with the future of healthcare. Where do you see it? I want you to respond to each of these bullet points. The healthcare bubble will eventually burst.
True. 100% true.
Either ACOs or first-generation clinical integration models will produce desired results.
True.
Physician autonomy and the organized medical staff will become less relevant.
True.
All right, so national healthcare reform, again, as a result of the Affordable Care Act of 2010. Now let's look at this. The healthcare bubble will eventually burst. Give me some supporting reasons.
We are not putting in enough money through taxes that can cover the cost. That it's essentially we will run out of money. That is a fact.
Go back and look how it was designed. How was it intended to pay for itself?
By people being healthier, not having to use it as much.
Bringing more people onto the plan.
More efficiency.
That's going to bring in more efficiencies, but that's going to bring in more money into the plan. Okay, more money should allow and attract more insurance companies to come in and more participants. You should have increased competition. That's going to lower costs. So more dollars being funded into the program and competition is going to reduce the type of cost. Where do we find it today? A majority of the people who have signed up for health care under the Affordable Care Act, which income bracket do you think I'm going to lean toward?
Lower.
The lower. More of them are going toward entitlement programs. Yes, we have increased the number of insureds, but how many are really directly benefiting from the Affordable Care Act? Competition. What's happening to competition in the program?
I mean, people are getting out of the business altogether.
People are exiting the business. Okay, I can show, and I receive headlines like this.
United Healthcare.
Last year, during open enrollment, I can share, as I'm in a health insurance agency, we saw United Healthcare was the first to come out and say, if you sell or promote any plan under the ACA, we'll accept it, but we will not compensate you. Do you think that entices me to come out and push a United Healthcare plan? They put that in effect for October through December. On January 1st, 2016, they said we will not accept any plans in 2016. Humana in our local market pulled out. For the most part of open enrollment last year, I had Anthem here locally to choose from.
Then you couldn't find providers.
And then finding providers. So we saw a decrease. Now, there's no competition when you've only got one plan. You're seeing right now across the country, more and more states are already coming out and saying, we are only going to have one provider. It's becoming such a reality that the president right now is floating the idea that our federal government might get in the insurance business.
Now, do you think that might have been part of the plan from the beginning? To try to push that single payer?
No, because I always go back to some of the failed legislations in the past, again, about trying to get the federal government, trying to shift that responsibility from the private sector.
Yeah, but what better way to do it than tank the private sector? And then have, you know,
Well,
the government
here's
come
what-
and save it.
Well, here's would be the idea though, is, and here's what I'm witnessing. Someone comes to me and says they need health insurance. I'm finding the healthy people who walk into my office, the first thing they say to me is, I do not want an ACA plan. They're opting to go off, and they're usually finding, I can find, if you're willing to do that and I can use you, I can go back and use and have you based off of yourself, they're usually getting a lower premium. Well, I feel like we're getting a less and less pull of, we're getting greater health risk within we're getting greater financial risk. My prediction, you know, again, 6 years ago, I'll never forget sitting in my office and getting 2 referrals for people who needed health insurance. Prior to that time, I would ask you questions like, what's your height? What's your weight? What's your past medical history? And I would use that information as a way of assigning a rating factor to you so that I could provide you hopefully with a close quote. These 2 individuals, they came to me and the first things they said, I want Obamacare. By the way, I'm terminal with cancer. I've never been able to have insurance before, but I understand I can get it now. And I said, I had to wait. Call me back in 1 week. They both come in that first week and I got on insurance. And I'll never forget sitting in my office and thinking, how, from a business model, could I prepare for that unknown risk? You know, the cost of insurance, spreading it across the masses. I need to be able to accurately assess what that cost is going to be and then try to spread it. They grossly underestimated the risk that was going to come through. I think in that first year, we had strong competition. Again, the insurance companies wanted to be in the market because they knew there were going to be this increased 32 million people coming into the system. Let's compete for this new business. And by the way, even if they can't pay for it, the federal government's going to step in and give subsidies. They're going to pay for it. But I think as we've seen now, increase and still continued losses, this is going to cite the Aetna deal, but Humana is already restricting the number of states that they're going to participate in. United Healthcare has already communicated that they are going to restrict the number of states that they participate in. I've not heard anything currently out of Anthem. You know, Anthem seems to be made of smaller regional markets. I think that kind of helps them across the country. So I think what we're seeing is we're seeing lack of competition. Nobody's competing. That's going to not give you the desired results. You're getting left with a higher risk, both medically speaking. You're also getting that from a financial perspective. Again, if they can't afford it, federal government's got to pay in and cover that subsidy. Next, what's our population doing? Well, it's shrinking, but what we have left here, actually our population is growing in a little bit, but from the age demographic, we're getting older. Okay, you're baby boomers. We're getting ready to see we're starting to see the full effect of what this age demographic is going to do in healthcare. We're going to see what it's going to do in retirement planning. All right, this is going to be a group from, 46 to 65. As they're moving through.
What do you mean 46? 46-year-olds are considered baby boomers?
No,
Bird
no.
boomers.
Thank God. Really would have pressed me then.
All right, so.
I'm over the wall.
You're telling.
I'm no problem.
All right, so again, as we start to see go back and look at who spent the most on healthcare, which age demographic. So again, we're going to be pushing those through. And I said 65, 64, your age, your last year for, so 1964 caps it. All right, so here we're going to see the 2017 presidential budget. And let's look at, here we see some deficit reduction. So we see some of these cuts down here. Yeah, I want the summary tables. Okay, so here is our receipts. This is going to be our deficit down here. So in summary, we definitely see outlays growing at a faster pace than receipts. So you see we're projecting increased deficit.
Sure are a lot of negative numbers up there.
Let's see here. All right, so of those outlays, know that these are always going to be broken down into discretionary programs. Discretionary programs will always be broken down into defense and non-defense. Mandatory programs, here are your entitlements and interest. So of all government outlays, we have three major categories: discretionary, mandatory, and interest. Your defense is going to be anything related to the defense of the country, including your military. Non-defense are going to include all federal employees, ranging from your parks to your elected officials. Your mandatory programs, Social Security, Medicare, Medicaid, and then interest. Now I charge you to kind of look some of these numbers, and our federal government receives most of its revenue in the form of individual income taxes. How far would income taxes go? All right, we would receive 1.5 trillion. We could not, we could not pay, I guess we could pay our federal programs, but not going to have a whole lot left. Income taxes alone cannot pay for mandatory programs. By the way, these income taxes, you see you're going to have a shrinking workforce, but at the same time, you see income taxes projected to rise. So I ask again, where do you see the future of healthcare?
I see less money in my pocket at the end of the day.
I don't foresee anything major happening another 15 years. I think they'll just keep making other incremental little, fix it, duct tape it.
Yeah, here's the thing. 2010, we're going on the 6th year. We're going under the 6th year of the Affordable Care Act. Again, it's been challenged by the Supreme Court. It's embedded. The one thing about it is if you brought more and more individuals under its care, you have increased its presence in American lives. I agree. I don't see the program going anywhere. Well, let me rephrase that. I don't feel it's here. I don't feel like it's going to be shut down. But I do think that we're going to see increase. We're going to see tweaks. Again, we're going to see, I think we'll see changes. I think we'll be forced to see changes. Right now, I can tell you it is not operating the way that slide envisioned. It is not operating the way it was envisioned in 2010. The reality is soaring healthcare costs. Again, when you look at what a percent of your income you're spending on it, and we look at what percent of the GDP that our country spends on it, as I said earlier, this is our economic problem. This is our deficit problem. This is our problem of the future. I don't think anyone argues everyone should be entitled, everyone should have access to health care. I don't think anybody argues you should have access to good health care. Next time a politician gets on a stump and promises to give and give and give, have the forethought to come back and ask who's going to pay for it. And is that base of who's going to pay for it sustainable?